Welcome to the Clinical Education Initiative podcast, Conversations with CEI, where we feature conversations with clinical experts, their experience and insights on current health issues in the areas of HIV, primary care and prevention, sexual health, hepatitis C, and drug user health.
Welcome to the Conversations with CEI podcast. This is Stephen Fine from the University of Rochester, CEI Resource Center. In today's episode, I'm going to run through a few of the topics about HIV that caught my eye at the recent IAS 2025 conference, the 13th IAS conference on HIV Science. This conference took place from July 12th through July 17th, 2025 in Kigali, Rwanda. The conference included over 100 sessions about HIV ranging from HIV science, treatment, prevention, implementing programs in resource-poor countries, battling social stigmas, and just about everything in between. Before we get started, I want to point out that on the International AIDS Society website, iasociety.org, there is a daily digest where each day of the conference is broken down into headlines for users to take a look. And by doing that, you'd be able to see all of the really important topics that I wasn't able to cover during this podcast. The program and abstracts from the conference are also made available on the website for those of us who were unable to attend in person, as much as I would have liked to go. That was a little bit too much travel for this summer for me. The overall mood of the conference, I'm told, was a bit somber due to the recently announced cuts in funding from the United States for HIV treatment and prevention programs around the world. But despite those devastating cuts, there was also a spirit of resilience in many of the speakers who pointed out that we have been here before and that we would not let this stop the progress that's being made in both treatment and prevention of HIV individuals. I'm just going to list some of the topics that are going to be covered during this podcast really quickly, in order for people who would like to skip ahead and not listen to all the fluff. I'm going to cover a presentation that discussed how U.S. funding cuts caused immediate drops in people being tested and on treatment in several sites throughout Africa. Lenacapavir and cabotegravir for PrEP is now supported in pregnancy and breastfeeding. Changes in antiretroviral medications did not reduce weight in people with HIV who were experiencing weight gain on antiretrovirals. A pipeline drug for monthly pre-exposure prophylactic, use of injectable HIV treatment for people who were not well controlled in Africa was successful, and use of a broadly neutralizing antibody with immunomodulators seemed to delay HIV rebound in patients who went off antiretroviral therapy. There were a number of presentations that attempted to quantitate how much of our footing would be lost due to U.S. and other countries' decrease in fundings for HIV prevention and treatment programs. One study suggested that when U.S. aid was paused in January of 2025 and grant holders and workers were told to stop work, HIV viral load testing in adults and children fell by 38% and 44% respectively. There were substantial decreases in treatment initiations, and that if the current funding cuts were to hold, there could be 83,000 new HIV infections by 2030, over 15% increase compared to current numbers, and that an additional 14,000 people would probably die of HIV-related complications. In Mozambique alone, as one example. Many speakers at the conference were hopeful, however, that some of the funding cuts would be restored and new sources could be identified. And almost every speaker mentioned that they've been through hardships before and they are resilient and will not give up. The next series of studies addressed the safety of injectable HIV prevention or PrEP during pregnancy and breastfeeding. The first one was data from HPTN 084 study, which presented data in 433 patients, of which about 2/3 were receiving cabotegravir at the time of pregnancy. Had received about 12 to 14 injections every 2 months prior to pregnancy and a median of 4 additional doses during pregnancy. There were no differences in outcomes across the exposed versus non-exposed patients, no changes in adverse events, no increase in small for gestational age births or congenital abnormalities. A small study presented by ViiV followed 27 mothers who were using cabotegravir and breastfeeding. They collected breast milk samples at 4 time points. Following the injections, found that cabotegravir levels in breast milk were extremely low. Also found extremely low levels of cabotegravir in breastfeeding infants' blood, suggesting that cabotegravir should be very safe for breastfeeding. Now, as a side note, they also looked at cabotegravir levels in the women when they were pregnant and shortly after birth and found that levels remain protective throughout pregnancy. And then finally, some of the data from the Purpose 1 trial of lenacapavir given to women to prevent HIV had a substantial number of pregnant and breastfeeding women in the trial and showed that outcomes of pregnancy for people receiving lenacapavir were comparable to those taking oral daily PrEP and as well as the general population. They also measured lenacapavir levels in breast milk and infant's blood, finding that only 2% of the level of lenacapavir in the infant's blood versus mother, suggesting that there is minimal exposure in breastfed babies. Birth outcomes were no different in the group taking lenacapavir versus oral PrEP, and there were about 193 pregnancies in the lenacapavir arm to be studied. Based on these data, the 2025 WHO guidelines now recommend that PrEP should not be discontinued during pregnancy or breastfeeding for women who are still at risk for HIV exposure. It was a study presented by researchers at Vanderbilt University who reported results from the DO-IT trial. That's DO-IT. They had 145 people with obesity who were virally suppressed on an HIV regimen containing at least an integrase inhibitor and tenofovir alfenamide. Those are 2 of the drugs that have been implicated in excessive weight gain in some studies of HIV patients. Participants in the study switched to doravirine, which is a non-nucleoside reverse transcriptase that has not been associated with weight gain, and either tenofovir alfenamide or tenofovir disproxil, TDF. They looked at change in weight after 48 weeks of follow-up, and it turns out that participants in all 3 arms, those on ongoing treatment, those changed to doravirine TDF, and those changed to doravirine plus TAF, lost a small amount of weight. However, there was no statistically significant difference in the weight changes between any of the 3 arms. The authors suggested that this is pretty good evidence that switching antiretroviral regimen is not effective in broad populations for decreasing weight. There remains a substantial interest in using injectable cabotegravir and rilpivirine for patients in the US and in Africa who are not virally suppressed or have a history of non-adherence to oral medications. The Impala study conducted in Africa compared cabotegravir rilpivirine injections to dolutegravir-based 3-drug oral regimen. All of the people enrolled had suboptimal HIV control with viral loads above 1,000 for the past 2 years and a history of being lost to care for at least 4 weeks or unlinked to care for 3 months after HIV diagnosis. Although these patients had detectable viral loads at the opening of the study, they were required to achieve viral loads below 200 before starting on injectable medications. In the end, after 2 years, there was no difference between people who were randomized to receive the injectable medication versus stay on oral medication, with 89% and 91% being undetectable in each arm. However, people claimed to very much favor the injectable medications. We are all quite tempted to consider starting patients who are not undetectable on injectable cabotegravir, rilpivirine. However, this was not exactly how they ran this study, although there is some other data out of California suggesting that this also is a safe and effective option for carefully chosen patients. The next study that I'm going to discuss is perhaps an early stage but potentially new option for pre-exposure prophylaxis for HIV, and that consists of a pill that you can take once a month. Even though I normally don't like to present phase 2 data in this clinical podcast, I thought this was worthy of mention. The presenter from Merck did point out that although there are some excellent injectable options, long-acting for pre-exposure prophylaxis, not everybody prefers long-acting injectable medication, as some people may not have access to injectables, and some people may prefer not to have injections. Therefore, the new oral medication MK 8527 could actually play an important role in pre-exposure prophylaxis because it's an oral medication that being given once a month. MK 8527 is a successor to islatravir and is a reverse transcriptase inhibitor that works both by stopping translocation of the reverse transcriptase as well as acting as a chain terminator. The phase 2 study presented at the IAS meeting gave 8527 once a month oral medication to 350 adults who were pretty low risk for HIV exposure. So again, it was not an efficacy trial. It included 60% women and about 40% were Black. And what it showed was that in the dose finding study of 3 different doses, once every 4 weeks for up to 6 months, 90% received all 6 doses, and it was very well tolerated, and the safety profile was excellent, reportedly similar to the placebo arm. Drug levels were measured and reached levels that were presumed to be protective against HIV infection. Merck plans to send this trial into phase 3 efficacy trial shortly based on the results of the study that was presented at IAS. There were some really interesting studies presented looking sort of one step closer to either a functional cure for HIV or perhaps an actual cure. One that caught my eye was a study of a broadly neutralizing antibody and an immune modulator called N-803. The broadly neutralizing antibodies are a set of antibodies that bind to a broad spectrum of HIV viruses and have been used in various combinations for years in order to try to suppress HIV replication. N-803 is described as an immune modulator named at interleukin-15, and it's a sort of potent agonist of interleukin-15, which kicks the immune system into high gear. 28 patients with chronic HIV infection who were stable and undetectable on antiretrovirals were given the combination of these 2 drugs. They received a single infusion of bNAbs and then up to 8 sub-Q injections of the N-803, each given 3 weeks apart. Then they stopped their antiretroviral therapy and only restarted if they had 4 consecutive weekly viral load measurements above 1,000 copies, or a CD4 count below 350, or symptoms of HIV acute replication, or if they became pregnant. By 24 weeks, 10 of the participants had viral rebound. However, 50% of the participants never had 2 measurements of viral load above 1,000, and 42% never had 2 viral load measurements above 200. 67% were off antiretrovirals at 20 weeks, 58% by 48 weeks, and 3 of the participants, which were 13%, didn't have to resume antiretrovirals even after 72 weeks. Again, this is early information and is definitely too early to try out on our patients, but it does give some hope to the idea that some combination of broadly neutralizing antibodies and these immune modulators may someday be useful in getting a functional cure, which is keeping the HIV suppressed or boosting patients' own immune system to suppress their HIV so that they can come off of antiretroviral treatment. Hopefully you've enjoyed this, what I'll call mini recap of the IAS 2025 meeting. These were only a very small sample of almost randomly selected topics coming out of the meeting that seemed important. I'm going to put links in the comment section to the abstracts that I discussed, as well as to the IAS 2025 website, where many, many more really great presentations can be found. This is Stephen Fine from Clinical Education Initiative, New York State AIDS Institute. Thanks for listening.
Thank you for tuning in. Join us next time for a new episode of Conversations with CEI. Visit us at ceitraining.org and follow us on CEI social media platforms.